So we have 18.
Okay. Okay, we start in 5 minutes.
If I may ask, how long is the meeting lasting?
It's up to Dr. Sabea. Generally, he takes about 45 minutes to an hour,
It's all right, thank you.
but it's kind of open, you know. Yeah, I'd like to go around before we start to introduce everybody, okay? So just be ready to unmute and just say, hi, I'm so-and-so from so-and-so, okay? Because networking is an important part of this and getting to know people. I'll tell you a quick story. What happened with one of Dr. Sabea's talks. He was giving a talk, and Michael Segru, a neurosurgeon in China, was listening, and he jumped in on the call and asked Dr. Sabea. Remember that, Dr. Sabea? He jumped in the call. Michael Segru.
Yes.
Yeah, he jumped in there, and that. Yeah, we just got a couple minutes. Let me get some more panelists. And yeah, Dr. Gaul's wife is going to start doing neuropathology. She's going to do a webinar.
Super.
You know his wife was a pathologist, neuropathologist, right?
Sure.
Yeah, I think I don't know if a neuropathologist or just pathologist, I'm not sure. But he says he consults her. on his cases.
He has to.
Yeah, I know. He better not refer someone else if he wants to eat.
Yeah, true.
Couple of minutes. Okay, everyone, please stay muted. Please, everybody. And keep your finger on that mute button, okay? Okay, we'll start 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning from Miami Beach. It's Dr. John Bennett of Neurosurgical TV. I have the pleasure today of restarting. Actually, there was a show Monday, but the Jordan Neurosurgical Grand Rounds with Dr. Abraham Sabea, a well-known educator, and he's been doing this telecast for a couple of years. And as you know, as most, it's getting crowded on the airways. We're getting a lot of people, so we're glad to see everybody. And I'm going to try to introduce everybody one by one, real quick. So just say your name, where you're from, and then I'll try to go to the next. Okay. Okay, Krishna, could you start, please? Go ahead, Krishna. Could you please introduce yourself? Hello. That's okay. Khalid Ashour.
Yes, this is Khalid Ashour. I'm working in Saudi Arabia. I'm an Egyptian neurosurgeon working here in Saudi Arabia in Mecca, Noor Hospital.
Welcome. Mohammed Sadek, please. Well, you know, Dr. Sabea, this will be a little problematic, so let me just cut that short. And welcome and thank you very much. And it's all yours.
Thank you. Okay, so it's Abraham Sabea from Amman, Jordan, and as you all know, we are in confinement. It's no movement outside the house, but it's a change of old habits that we are used to. Today, I'm going to discuss trigeminal schwannomas in general, with the usual approach of clinical, radiological, operative, and pathological correlation. Before that, last time I spoke about how Jordan is a country known for religion tolerance, where Muslims, Christians, and Jews lived in harmony and in peace for centuries. Jordan is the site, the recognized site for the baptism, where St. John the Baptist baptized Jesus Christ at the Jordan River. In Matthew 3:13, it reads, Jesus came from Galilee to join at the Jordan to be baptized by John the Baptist. And in Matthew 3:16 to 17, it reads, As soon as Jesus was baptized, he went up out of the water. At that moment, heaven was opened, and he saw the Spirit of God descending like a dove and lightning on him. This is an old mosaic map in Jordan, in Madaba, a Christian town in Jordan, which is just depicting the Holy Land topography. And here you can see also another mosaic map in Jordan where it shows River Jordan going down to the Dead Sea. So this is Jordan River where baptism was carried out and still carried on. And it is called Bethany Beyond Jordan, and it is a recognized UNESCO World Heritage Site. This is the Basilica, Church of Trinity, and you can see the mountains and the hills leading to the Dead Sea and Jordan River. And this is a close look to the inside of the Trinity Church at the baptism site at Bethany. This is the baptism pool, another view of it. And adults or young children are baptized there. And this is where His Excellency, His Highness, Pope Francis visited Jordan a couple of years ago. And this is when he went down the marble steps to put some water on his hand in the River Jordan. So that's just a brief look about the baptism site in Jordan. We'll go now for the presentation, the trigeminal schwannomas. One has to start by saying some anatomy so that we can go through the road. The trigeminal nerve starts in the brainstem and the pons, and here we have 4 nuclei. 1 motor nuclei, which is small, and the 3 sensory nuclei. The main sensory nucleus is this one, the mesencephalic nucleus is this one, and this is the spinal nucleus of the trigeminal. So 3 sensory nuclei and 1 motor. And you can see 3 sensory because the major part of the trigeminal nerve is sensory and a small part is motor. Now, this is another depiction of that. This is the mesencephalic trigeminal nucleus. This is the main sensory nucleus, and this is the spinal sensory nucleus. So the 3 will give the large sensory root, and the motor nucleus will give the small sensory root. And by the way, this is here showing the abducent nerve nucleus, and this is the facial nerve nucleus, and how the facial nerve fibers go around the abducent nucleus. So people speak about facial colliculus. This is not the facial nerve, this is actually facial nerve fibers going around the abducent nucleus. So trigeminal nerve comes off the mid-lateral surface of pons, like in this one here. And then it goes straight forward to go into Meckel's cave. Here you can see the large sensory root, and here underneath the large sensory root, there is the small motor root. Again, you can actually differentiate the large sensory from the small motor root. And then here we are looking at the base of the skull where the trigeminal nerve goes into the Meckel's cave. Again, you have to appreciate this anatomy relationship of the abducent to the trigeminal, which is an essential piece of anatomy if you want to deal with the trigeminal nerve. And of course, here the internodentine meatus and lower cranial nerves. So here we are again, the trigeminal nerve going into Meckel's, relationship with the abducent. So you can see this is abducent, trigeminal, 7/8, and lower cranial nerves. And then here lower down is the hypoglossal nerve. The relationship of the trigeminal as it goes into Meckel's cave is not sort of regular. It can be anything. Here you can see the superior petrosal sinus. So the relationship is either the superior petrosal sinus is above the nerve, or it can be below the nerve, or it can actually surround the nerve. Again, this is a piece of anatomy that needs to be remembered. By the way, Meckel's cave is named after Johann Friedrich Meckel's, a German anatomist. So here we are again. We are looking at the back of the clivus. So here the dura is still there. Here we remove the dura. Again, you can appreciate the relationship. This is the 3rd nerve, this is the 4th nerve, is trigeminal and abducens. Here, as you remove the dura, you can appreciate the venous plexus there, and you can see this ligament underneath which the abducent nerve passes. So it's a close relationship between the abducent and the trigeminal, and one has to remember this quite vividly. Again, here we can see the trigeminal nerve going into Meckel's cave, and then here the ganglion dividing into trigeminal, maxillary, and the ophthalmic nerve, the relationship of the abducent. So again, this is the impression for the trigeminal nerve, like in here. And the abducent nerve takes this course and goes into lateral pedicle artery to the superior orbital fissure. Here, as again, we are looking at the same picture, that the abducent nerve passes underneath the ganglion here and underneath the Gruber ligament. And so Gruber, who defined this ligament underneath which the abducent nerve passes, Gardenengo, who described the syndrome, and the Rollos are famous for their work. Again, I have to say that this picture, I took it by myself with my camera in the cadaveric lab of late Dr. Albert Rutan. I attended many cadaveric courses there, and I recommend that everybody should go there. I actually did it for so many years, and you don't need to be a medical student or resident to go there. A full consultant of neurosurgery should do some cadaveric work. So here we're concentrating on this side, which is the left side, the trigeminal nerve going into the Meckel's cave and dividing into V3, V2, V1, a relationship with the carotid artery, with here you can see internodentary meatus, the facial cochlear, this is facial anterior going into the geniculate canal, and this is the greater superficial petrosal nerve on top, on the upper surface of the carotid. Here, of course, we have the eustachian tube, bony eustachian tube, and the cartilaginous in front, and the relationship of the middle meningeal artery to V3. Another closer look here. The trigeminal nerve has passed through Meckel's cave. This is the Khazarian ganglion. This is V3, V2, and V1. Relationship of the ganglion with the carotid. This is the so it goes underneath the trigeminal. Relationship of the middle meningeal artery and the relationship of the great superficial nerve. Closer look again. This is the carotid and the greater superficial petrosal nerve running over it. Here is the eustachian tube. So you have to remember this relation. The middle meningeal artery, the eustachian tube, the greater superficial petrosal nerve, the carotid artery. Here is the cochlea, and this is what we call as Kawase triangle, which I will describe later. So when the trigeminal nerve passes into three parts, the V3, V2, and V1, the space between V3 and V2 is wider than the space between V2 and V1. And here, if you dig, you'll go into the sphenoid sinus. Similar picture here. We can see the V3, V2, V1 relationship, the greater superficial petrosal, and the middle meningeal artery. Same thing here. And you can see there is this glistening area here. This is the membranous part of the dura covering this lateral wall of the cavernous sinus. So the lateral wall of the cavernous sinus, which is here, is composed of two layers, the periosteal part and the membranous part. Closer look at the Khazarian ganglion, V3 and V2, and the greater superficial petrosal nerve. Same here, the artery. These views are from Vinko Dollin's beautiful books. He wrote 4 books on the cavernous sinus. Vinko is a great man with a great experience in the cavernous sinus. And this is the greater superficial petrosal nerve going on top of the carotid artery underneath the trigeminal ganglion. Closer look again at the greater superficial petrosal nerve. Of course, as you know, greater superficial petrosal nerve joins with the deep petrosal nerve, form the nerve of Vidian canal that goes to the pterygopalatine fossa. Again, the V3, the V2, the V1, the spaces between V3 and 2 wider than the space between V2 and V1. Here is the foramen rotundum, foramen ovale, this is foramen rotundum, and here is the going to the severe orbital fissure. Same picture, V3, V2, V1, and you can see here the oculomotor nerve, and you can see here is the abducent nerve. So, finishing the Gazanian ganglion, the trigeminal nerve divides into ophthalmic part, the maxillary part, and the mandibular part. If we take the ophthalmic part, V1, its main parts of it is the frontal nerve, which gives to the supraorbital, supratracheal nerves, and the nerve that goes to the lacrimal gland called lacrimal nerve, and the ciliary, nasociliary nerves that goes, the short and long ciliary nerves that goes to the ciliary ganglion, in addition to giving us the anterior and posterior ethmoidal nerves. The maxillary nerve, as it comes from foramen rotundum, its relationship with the pterygopalatine fossa, it gives us several alveolar branches called superior alveolar branches that goes to the teeth, and then it continues its way to form the infraorbital nerve. And then its way, it gives this branch that's called the zygomatic branch. So zygomatic branch like this, the infraorbital nerve going in the inferior orbital fissure and comes out as the infraorbital nerve. The mandibular nerve, V3, this is 1, this is 2, this is 3, comes from through the foramen ovale, and it has a relationship with the internal maxillary artery. The main branches are obviously here, the motor branches to the mastication muscles, masseter, temporalis, vaccinator, mylohyoid, etc. And also it gives the lingual nerve, as you can see it here, and the inferior alveolar nerve. So this is why am I mentioning this? Because each of these branches, V1, V2, V3, in addition to all the branches that I mentioned, they give a branch to the dura. So major nervous innervation of the dura is coming from the trigeminal. And if you are operating on that area, there is something called trigeminal cardiac reflex. I've faced it many times. You just do something with the dura, and then the anesthetist will tell you that there is a bradycardia and hypotension. So this is called the trigeminal cardiac reflex. And it was coined by anesthetist, actually, Shelley and Church, 1988. So decrease in heart rate, decrease in blood pressure. As you are waiting, as you are working, the anesthetist will alert you to that. So this is a parasympathetic reflex, but involves the divisions of the fifth nerve, the brainstem nuclei, and the vagus nerve. So it goes like this. You get this sensory pain stimulation that goes to the vagus and from the vagus to the heart, and that's the cause of the bradycardia. And this can happen in any type of surgery involving the trigeminal nerve. So dentists can have it, ophthalmologists can have it, and we as skull surgeons can have it. Any procedure on the head can cause this. So again, here's the divisions of the three nerves of the trigeminal nerve. And that takes you to the cavernous sinus. This is amazing structure that when you understand it, you actually disclose the secrets of the skull. So you need to know the triangles, and the most famous is the Parkinson triangle that was first described as an approach to the cavernous sinus. For me, that fascinated me as a medical student, that fascinated me as a resident. And what happened that as I was a resident training at St. George's Hospital, at Consomoli Hospital in Wimbledon, London, I published this paper about traumatic carotid cavernous fistula. I was still a young neurosurgical resident, 84, and published in Journal of Neurosurgery. For me, that was really an asset, something to put under your belt, and you walk with head high as a resident to publish something in Journal of Neurosurgery. So back to the anatomy, bony part. If you look at the skull base in the middle here, you can see foramen ovale and foramen spinosum, and here is the foramen lacerum. Foramen rotundum is here. You don't see it in this view. You have to tell this skull to see it. So we have separated the four bones here, and this is the sphenoid. So foramen spinosum for middle meningeal, foramen ovale for the trigeminal nerve, and foramen rotundum for the maxillary nerve are seen. So because you tilted the skull, you could see them. If you look at the sphenoid bone from the back, this is dorsum celli. You can see anterior clinoids, rear orbital fissure, and then immediately you can see foramen rotundum and foramen ovale. If you look from front, in addition to the foramen rotundum, you can see the canal for the median nerve, and this has been used extensively as a landmark in endoscopy. So here again, this piece of bone here, the petrous apex, the trigeminal impression, the foramen lacerum, the foramen ovale, foramen spinosum, and foramen rotundum. So we have spoken about the trigeminal nerve anatomy. What about the schwannomas that arise? Schwannomas means arising from Schwann cells, and they can arise from any cranial nerve, peripheral nerve, or autonomic nerve. There's a difference between schwannoma and neurofibroma. Neurofibroma is central, schwannoma is peripheral. Schwannomas in general constitute 7% of intracranial tumors, and they are more common in females. So they are arising mostly from sensory nerves, and vestibular schwannomas are the most common. Everybody knows that vestibular is a very common lesion. The non-vestibular schwannomas, other than the vestibular schwannomas, only 10%. And trigeminal nerve comes first, followed by lower cranial nerve, followed by facial, abducent, oculomotor, and tracheal. In fact, I have one case only through the last 35 years being a neurosurgeon. I had only one case of abducent nerve schwannoma, which I may present to you on another date. So trigeminal schwannomas are rare. They constitute 8% of all the intracranial schwannomas, and it is the second most common after vestibular schwannoma. It can be solitary, it can be part of schwannomatosis, it can be part of NF2. This is one of my cases, 16-year-old male patient with this solitary trigeminal schwannoma. This is a case of mine, an unfortunate 11-year-old male boy, patient with this trigeminal schwannomas, huge ones. And again, this unfortunate female patient of mine, 20-year-old, with this multiple tumors in NF2. So trigeminal schwannomas, they can arise from trigeminal nerve anywhere along its course, from the cisternal part, from the ganglion part, from the divisions. Which is the commonest? The commonest is to come from the ganglion. So here we are looking on the left side, Michel's cave, the nerve, ganglion, V3, V2, V1. So the tumor can arise from the cisternal part as such. Cisternal part going into Michel's cave, cisternal and ganglion, like this, part in the cisternal part in the Michel's cave, ganglion alone, which is the commonest type, like this one. So the Gazerian ganglion schwannomas are like this. This is actually a cadaveric picture with a balloon put in there to show you the relationship. And this is a view from Al-Mefti book. So here they are, they have put some catheter and they've blown it up so that you can see that part of the tumor here is within the Michel's cave, part is in the posterior fossa, and you can see the filaments of the trigeminal ganglion. So tumors also can arise from the branches of the divisions of the trigeminal. V1 branch, like this, maxillary branch, like this. So it's all peripheral, it's all extracranial. And a V3 tumor like this. So you can have tumor that's starting from here and going outside. Classifications for trigeminal schwannomas. I have come across so many classifications, whether by late Albert Rotun, by Majid Sami, by Vinko Dollins, by Ramina, Fukushima, Kawasi, Al-Mefti, and others. And I came to a conclusion that the simplest and most applicable classification is that of Sami. But let me just go through them quickly. These are pictures of these gens which I mentioned, the late Albert Rotun. I feel a personal loss because we lost that man. This is Majid Sami, this is Vinko Dollins in the streets of Amman, Simon Mifty and Takeshi Kawase and Ali Crest, all are friends of Jordan, friends of me, friends of my family. Fukushima classification, A, B, C, D, and D, A, D, B. I don't want to go into the details. Ricardo Ramina from Brazil published this paper 2008 about a way of classifying these schwannomas. Kawase classification, having discovered the Kawase triangle, he came up with this classification, which is a bit complicated. But as I said, I adopt, and I think this is easy to understand, easy to apply. And I think this kind of classification should be also known not by the neurosurgical residents and the neurosurgeons or skull-based surgeons, that should be also known by the radiologists who write reports. It is not enough, to my mind, to my thinking, that a radiologist say this is a schwannoma. He must describe the type of schwannoma. So type A, because the Michel's cave and the Gazelle angle is in the middle fossa, so this is the commonest type, type A, mainly middle fossa. Here is mainly posterior fossa, type B. Both fossa, middle and posterior, called dumbbell, or it is totally extracranial in V1, V2, and V3. So this is A, the middle fossa type, the commonest type of the meningioma, of the schwannomas. This is B, the posterior fossa type, where part of the tumor is mainly in the posterior fossa, like this, like this. And the type C, which is dumb, both fossae, middle and posterior fossa. Or it is totally in extracranial. This is V1 tumor, this is V2, this is V3, and this presenting into the pharynx, into the heart palate. Or it could be, as I said, both extra and intracranial tumors. So both extra and intra tumors like this. One of the people who described this is Atul, and I was told I missed it actually. I wanted to be on the panel for the Atul presentation. Atul is a great man. He's a great friend, and he has a vast experience. He published this paper in 2010 about his experience with the trigeminal schwannoma. And usually, as usual, Atul has these large-sized tumors. Can they be malignant? Of course they can. And this malignancy can be de novo or benign that transforms into malignant. And in this case, we call them malignant neurofibroma or neurofibrosarcoma, neurosarcoma, malignant neurolymphoma, malignant nerve tumor, all the same to describe these malignant schwannomas. So this is one of the cases described in 2001, malignant schwannoma of trigeminal nerve, de novo type of thing. How do they present? You would expect that the most presentation is a trigeminal neuralgia or trigeminal hypoesthesia. Look at this, trigeminal neuralgia only 30%, hypoesthesia is 20%. Most of the time they present like this: headache, ear pain, eye pain, double vision, and other complications like cerebellar signs and lung tract signs. If you see a case of a trigeminal schwannoma and you think it is trigeminal schwannoma on MRI, what is your differential diagnosis? Again, this should be known by the radiologist reporting on these cases. Alas, most of the neurologists reporting on these cases, they do not know these classifications. They should. So, schwannomas, oculomotor is very rare, but look at this. Trochlear, very rare. Trigeminal, as we described. Abducent, vestibular, they all look the same, and they could be anything. But you have to keep that in mind. Facial nerve schwannoma, this is a case of mine. Vagal nerve schwannoma, case of mine. Accessory, hypoglossal, all these are cases of mine. Petroclival meningioma, very much looks like trigeminal schwannoma. Giant cell tumor, large cell medulloblastoma going into sepia angle, metastasis, arachnoid going into that angle, chordoma, chondroma, chondrosarcoma, epidermoid, hemangiopericytoma, endolymphatic sac, a patient of mine, a glomus jugulare, aneurysm of either the basilar artery or the petrous carotid artery, cavernoma, a huge cavernoma within the cavernous sinus, metastasis, a glioma, dermoid. So all these CEP angle lesions, histiocytosis, fibrous dysplasia, neurosarcoidosis, cholesterol granuloma, and lymphoma. And all the lesions in the petrous apex. Simple effusion, fatty marrow, mucocele, apical petrocytes, encephalocele. This has also to be remembered. Now, when you see this wide differential diagnosis, you would be surprised how people would treat these lesions with radiation, with gamma knife, without having histology. What is the treatment of the trigeminal schwannomas? Treatment of choice is surgical resection. This is accepted all through by everybody. Prior to 1956, mortality rate was high, 50%. But with the advance of neurosurgery, neuroimaging, monitoring, physiological monitoring, microsurgical facilities, microscope, skull-based approaches, things are getting brighter. Again, complete tumor resection with minimal morbidity is your aim, and you need to have this 3D in your mind of anatomical knowledge. You don't rely on navigation. I repeat the words of the great man of neurosurgery, Professor Yazajil, who always says that your navigation is your brain. Don't rely on navigation. Use it, but depend on your 3D knowledge of the case. Now coming back to the cavernous sinus, and as again here, the dura here is made of two layers, the one layer that goes outside and the inner layer. So this is the periosteal layer, this is membranous layer. And of course, there is another layer deep inside. So this has to be remembered operating on these cases. So the importance of using the interdural meaning that I will go between this yellow and the green. Here is this beautiful paper published by Kawase showing this relationship between the two types of the dura. And again, this beautiful paper by Takeshi Kawase about this. So this blue is the membranous dura, and this interrupted line is the meningeal dura. And you can see you can work in this space between this and that without entering the cavernous sinus. So it's really that some neurosurgeons may not have operated, not have the chance to operate in a single case of trigeminal schwannoma. They are rare. So the people who should do the surgery should be the experienced surgeons, not the novices. Sam al-Mifti is one of those giants, taking this dumbbell-shaped schwannoma completely out. Lilham Shaker from Seattle, again describing his non-vestibular schwannoma experience, 7-year experience. Atul Gowar, again, he had a very big series. And if you look at the complications he has, CSF leak, meningitis, because if you operate, you will have some complications, that's understandable. And here is the postoperative new cranial nerve, which is the commonest complications, to have a new cranial nerve complications. Surgical approaches, so many, and I will describe some of these cases. Now with the introduction of endoscopy, things are brighter, and I keep saying that the future of neurosurgery relies in the hands of the endoscopy, how much it is going to progress. So 15, 20 years time, things will be all done by endoscopy. So anterior petrosal, surgical, posterior petrosal, retrosigmoid, or you can go through the orbit, you can go through the sphenoid, you can go through the grading canal using the endoscopy techniques. Endoscopy, as I said, so many techniques. It's had evolved in a very, very major way, and it is so interesting and so informative. They are teaching us new pieces of anatomy that we did not see before. And the giants of neuroendoscopy are well known to you. Charles II in Australia, Amin Kassam, Schneiderman, Gardner, Gap, Schwartz, all are eminent people in endoscopy. Here is Charles II and myself on a trip over the Nile. This is the picture of the endoscopy picture. You can see the trigeminal nerve, you can see the cerebellar artery, you can see vein of Dandy, just beautiful anatomy, and this is the tentorium. This paper, again by a group of Amin Kassam, It says the front door to Mickel's cave. So you go into the sphenoid sinus, and then you go laterally to the Vidian canal, and then you would come across the V1, V2, V3. So you'll be actually in the front door of the Mickel's cave. And here the actual cases that they have done. Another paper, 2014, surgical management of trigeminal schwannoma using endoscopic approaches by Schwartz and his team, Vijay Anand and the others. You can see they have taken most of the tumor out. So they have gone this way. They have gone through the sphenoid and then went this way. Another paper from, again, Vijay Anand and Theodore Schwartz, published in neurosurgery, and you can see you come across the front door of Mickel's cave. Look at this very beautiful piece of anatomy using the endoscope. This is cadaveric specimen. And this paper again coming from University of Vienna. This paper from Schneiderman and the group, non-vestibular schwannomas. There is some remnant there, but it is okay. Again, endoscopic transorbital approach for this trigeminal schwannoma. So you can use surgery and assisted by the endoscopy, and this is a beautiful paper demonstrating this in a very big way by Majid Sami and his group. And you can see that there is some sort of blind corners that one needs to see, and when you use the endoscope, you can find them. What about radiation for these cases? I speak of from the stance of experience with the gamma knife, because I was the first neurosurgeon operating on any case in the Middle East. We brought the gamma knife back in June 1996, but I always felt that this is another tool, and a fool with a tool is still a fool. So one has to be very careful about how to use this very important, very useful machine. You need a person who can use it properly, not a person who is not experienced and who has no idea about surgery, who will use it for any case, come what may. This paper, again, showing the papers published about radiosurgery for trigeminal schwannoma, but look at the tumor volume. It's a small tumor volume. Now, small tumor volume to treat them with radiation, I don't go with this, because small lesions can be actually easily, completely be excised. This paper from Pittsburgh, from Dave Lansford and his group, again showing this sort of, yes, it is smaller, but the tumor is there. It is still relating to the trigeminal nerve. Gamma knife, the title here says, gamma knife surgery and trigeminal schwannoma. Is it possible to preserve cranial nerve function? The answer and the conclusion is no. It says, cranial neuropathies are bothersome complications of radiosurgery, and tumor expansion in the cavernous sinus after radiosurgery appears to be approximate cause of complications. So again, they show you this kind of cases. The region is there. I have not seen one single case of trigeminal schwannoma disappearing completely, trigeminal schwannoma or any other region for that matter. This is a complication of gamma knife. This is one of the complications of gamma knife. Pseudo-capsule formation. Why should you treat something with radiation when you can remove it with surgery with minimal morbidity? Why should you not consider the late complications of radiosurgery, i.e. malignant change or return and recurrence of the tumors treated? Again, another paper, again showing the volumes that are treated are really small with radiation. Once again, I believe that the mainstream of treatment for this trigeminal schwannoma is surgery. This is another paper by Jason Sheehan from the Charlottesville, Virginia. And you can see the region is still there, but again, this is what we have. So different papers publishing about the trigeminal schwannoma and gamma knife. I will go now to my series between 90 and 2018. And why do I stop at 18? Because at least you need 2 years to include any case in your series. I had I was lucky to have this number, 38 patients in a country which is only 7 million population that has increased recently to 10 million by the influx of refugees. So to have 38 patients of trigeminal schwannoma, I've been lucky. 38 young adults, female more than males, and this is frightening. Size is usually large. That's what I get. 4 centimeter large, 20 cases out of the 38. Some peculiarities of the cases I have, this case, as you can see, it's going into the severe orbital fissure, completely destroying it. This was a 15-year-old female. And this is a 43-year-old male patient with this tumor that is only located in Mickel's cave. And that brings to mind the sign that's called winking Mickel's cave. So one Mickel cave is empty and there's a tumor in the other, as if Mickel's cave is winking at you. I had this unusual case. Okay, this is arachnoid cyst, I understand. I thought this is all acoustic neuroma, acoustic schwannoma, vestibular schwannoma. But when I went in, I removed this and then I found another trigeminal schwannoma. So there were 2 schwannomas, kissing schwannomas, one from trigeminal, one from vestibular, in addition to this. So I called it triple pathology. Again, this is some of my cases. As I said, the large side is the cardinal feature of these cases. I was able to do gross total resection in 23, near total or subtotal in 15 cases. I had recurrence in 4, but I did not have any mortality. My series of the complications, like all the others, 6th nerve complication increased deficits. Other nerves are less. So the commonest to increase in deficit is 6th nerve, CSF leak, hematoma, and others like fever and meningitis, etc. So going through some of the illustrative cases, this lady, 62, came from Qatar with this trigeminal schwannoma. We removed surgically via setting position, and she's well. A 53-year-old female patient with this dumbbell-shaped schwannoma, again removed completely. And here you are seeing her post-operative. And this lady who came from Palestine with this 52-year-old female lady with this huge dumbbell schwannoma, which we removed completely, and she's well. Last case, I want to share it with you because we have a video to show. And this I would leave to my daughter, who is a neurosurgeon. She's 5th year neurosurgical resident, to present the clinical presentation of this patient.
Hello everyone from beautiful Amman. My name is Asil Sphen. I'm a 5th year neurosurgical trainee in the Royal Medical Services here in Amman, Jordan. It is my absolute pleasure and honor to be with you and to present this case. So let's get to it. Our patient is a 50-year-old female patient coming from United Arab Emirates. She had a long-standing history of 10-year duration headache, left ear pain and tinnitus in association with left facial numbness. Actually, these symptoms constellated together should have prompted her primary physician to do some workup. Unfortunately, that was not the case. Her past medical history was significant for hypothyroidism, for which she was on treatment. Past surgical history of cholecystectomy and tonsillectomy. Vital signs were normal. General examination was okay. Neuro exam was normal. Extraocular muscles were intact, and facial nerve, fortunately, was intact as well. Neuro exam regarding the cerebellar signs, all were intact in addition to her gait. Looking for upper motor neuron signs, there were none. Obviously, her power was 5/5 all over her right and left upper and lower extremities. Reflexes were normal, negative Hoffman, pronator drift was negative, in addition to the plantar reflex, which was downgoing. This is the patient showing no signs of pronator drift. Her chest X-ray and ECG were normal. her pre-op labs, which included CBC, bleeding profile, kidney function tests, and liver function tests were within normal range. So going to the pre-op imaging, now we have this brain MRI axial cut, T1 without and with contrast axial cut, showing here this hypo-intense mass lesion in the area of the trigeminal nerve distribution involving Meckel's cave and the cavernous sinus, and extending into the posterior fossa as shown here. And we can see that after the IV contrast administration, it had a heterogeneous enhancement pattern. More axial cuts going downwards. We can also appreciate the Meckel's cave and the cavernous sinus involvement. Also here, this T2 image, which we can see that the tumor fortunately did not involve the internal auditory canal. And we can see here the 7th and 8th nerve going smoothly into the internal auditory canal. And here we can see the shadow of the carotid segment of the petrous segment of the carotid artery. And here is the same shadow contralaterally. And this, of course, prompted us to do a brain CT to assess for the bone integrity in that area. This is a diffusion image showing restriction, as we can see here. This is a coronal cut with IV contrast, which here we can appreciate the cavernous sinus involvement here on the left side in comparison to the right side, and the fullness of the Meckel's cave here, as we can see. Sagittal cut with contrast here and T2. And coming to the brain CT bone window, this is the coronal cut, this is the axial cut. Here we can see the normal internal auditory canal with the overlying tegment tympani. It's normal, it's intact, and here we can see loss and bone destruction of the tegment tympani. Here we can see the bony destruction of the petrous apex, and in comparison to the right side, which is intact. This is the MRA, and these are the MRV images for our patient, which is essential and basic for every patient going into surgery. Luckily, the patient did not have any stenosis of her major vessels, especially the petrous part of the carotid artery, and no venous anomalies. This is an overview of the images of our patients. And since she had left ear tinnitus, we had an ENT consultation, and her examination showed sensory neural hearing loss in her left ear in association with left high compliance and high stapedial reflex, all explaining her left ear tinnitus. These are her exam. And last but not least, our tailor-made consent form, which is tailored for every patient, mentioning the preoperative findings and the possible post-operative complications, the possible use of post-op chemo and radio, and the possible also use of anti-epileptic drugs post-operatively. Now leaving the floor for Dr. Sphen for the surgical approach. Thank you.
Thank you, Asil. Now going to the surgical approach in this case, this is the inside of the skull, this is the middle fossa. So I have put the skull in the position where the patient was. The patient was on her side. So we'll be attacking the tumor, which is here in the lateral position. So this is magnified view. So I will be coming this way. This is petrous apex. This is foramen lacerum, foramen ovale, foramen spinosum. So I know exactly that I'm going here, and I want to know the anatomy very well. So here you are. Everything is covered by the dura, but you have to keep it in your mind. It says your brain is your navigation. So this is the cadaveric specimen, the bone flap, frontotemporal, You go down to the base of the skull so that you will not do lots of temporal retraction. All this surgery is going to be done extradurally. So here we have removed the bone flap. This is the temporal dura. This is the frontal dura. And this is the clinoid process. Now here I'm putting you some of the still pictures of the surgery. So I'm putting cadaveric picture and operative picture. So here, frontal dura, temporal dura, this sphenoid wing, and you can see here that we are dissecting the dura off and drilling the anterior clinoid. In the cadaveric specimen, you can see that we'll come here frontal, temporal, you'll come across this meningio-orbital band, which is very important. It's landmark for the superior orbital fissure. And I have to open this band so that I can retract the dura. If I don't, the dura will not retract with me. And you have to open it carefully by tangential so that you will not affect any nerves, especially the third nerve. Here I'm using the knife, as you can see, tangentially to cut this band. And then you start dissecting the dura, both the periosteal and the meningeal together this way, medially. And then you will see the middle meningeal. This is your landmark for V3. This is the greater superficial petrosal nerve. So V3 and foramen ovale, sorry. Here I'm identifying this is operative view, identifying the middle meningeal artery and cut it. And then continue the dissection of the dura of the bone. You will find two ridges, the first ridge and the second ridge. So you have not to mistaken that you have reached to the limit here by just reaching the first ridge. There is another ridge there. And here, this is landmark, the landmark for the superior canal. Again, you would like to come here. This is the area of the Kawase triangle, better called rhomboid Kawase area. Arcuate eminence, as I said, is the landmark for the superior semicircular canal, tegment tympani. This is the facial hiatus. The geniculate ganglion is here, sending the greater superficial petrosal nerve. So it goes like this: seeing the middle meningeal, you see greater superficial petrosal, you go to the V3, knowing that this is the area of bone of the Kawase and that the cochlea is just there. Again, all this is in your mind. Here is an operative view of the patient that will show you its video. We have cut the middle meningeal artery and dissect the dura off. As I said, you will see the greater superficial in V3. So this is greater superficial petrosal V3, and you can see that if you retract the V3, you'll see the greater superficial on top of the surface of the carotid artery. Same picture. Here, this is the operative view. This is middle meningeal being cut. Here I'm at the foramen ovale. I'm widening a little bit the foramen so that I can know the pathology better. So dissecting, as I said, you have two ridges, first ridge and second ridge, as you are dissecting the dura off. Again, the same picture. Here I'm using the Doppler to make sure that I'm safeguarding the carotid artery. Here I'm dissecting both the meningeal, the periosteal layer of the meningeal part, and I'm coming across the tumor. All this is extradural. And then I'm opening the capsule of the tumor, going inside the tumor, widening the opening, proceed with the removal of the tumor. I am after every ion of the tumor. I'm not going to do simple resection or biopsy and send for radiotherapy. The aim is to remove the tumor completely. And here you can see that I am here at the dura of the posterior fossa. This is actually the arachnoid. So let me tell you this. This is the Kawase triangle that I should drill to reach to the, say, petroclival meningioma, the upper part of the clivus. But here the tumor has done the bony resection for me. The bone is reabsorbed completely. and then you'll come to the dura of the posterior fossa with the arachnoid. Here you are. This is the Gazarian ganglion, and these are the filaments, and this where the tumor actually did arise. Here are, you can see the filaments of the Gazarian ganglion, and here should be V3, and here should be V2. Again, here checking the Doppler once more, and you can see here, this is the greater superficial protrusive nerve. At the end, I would obliterate this space by putting some fat, which I took from the thigh of the patient, with fasciolata, glue, and then putting some dural sealant to prevent any CSF leak. I use the navigation in this case to make sure, as again, my navigation is my brain, my anatomical knowledge is my navigation, but this would give you extra assurance that you are doing the right job at the right place. Let me show you now the video. The video usually we record it in 3D, but because I don't know whether all the participants, the panelists, having any 3D glasses, so I'm turning the 3D into 2D. But in the usual case in Jordan, we have been doing the 3D recording and teaching for our medical students and residents with the 3D models. As this is the picture that, as I said, you drill the bones that they are in flush with the base of the skull. So you are here at the base of the skull, starting the dissection, cutting some of the arterial supply, meningeal branches. Continue the dissection. Here you are actually taking both layers of the dura, the periosteal and the meningeal part, and you just go medially, and then you just separate the membranous part from the periosteal dura. Here is the frontal here. This is temporal, the sphenoid wing. We have drilled the sphenoid wing because I want to reach to the superior orbital fissure here, without which, if I don't open it, I cannot really dissect properly. I cannot see the extent of the tumor. So here is the anterior clinoid process. I don't need to drill that completely. I just go as much as I can so that I open the superior orbital fissure, and that can be done by opening of the meningio-orbital band. And here I'm cutting part of it. Still, I'm not happy. I want to open it completely. So I bring the dissection again, go more deeper. So the superior orbital fissure is just here. Now I take the knife and cut it tangentially, not across, but tangentially, so that I preserve the contents of the superior orbital fissure, and in particular here, in danger is the third nerve. So you can see that we have done this dissection of the dura off. Here I use this trick. I put some diathermy on it, on the dura, so that it will a little bit shrink and give me a better view. Here I'm trying to cut the middle meningeal artery, and I usually cut it away from the spinosum because I don't want it to slip inside and then I lose it. So it is being cut here. So I know if I go this way, I will come across V3. And indeed, here I am at the foramen ovale. I'm putting this dissector inside. So this is foramen ovale. I widen it again to have more exposure. I'm using Roton dissector here. So this is V3, and the dura covering V3, I should say. So spinosum, and then foramen ovale with V3, and then I would go to V2. So you can see V3 here, V2 is here. Again, spinosum, V3, and V2. The distance between these is wide, and if you dig here, you will go into the sphenoid sinus. Here is V2, and here is the superior orbital fissure. So again, here you would find, come across some of the bleeding, extradural bleeding, which you can control. I'm not worried about the the greater superficial petrosal nerve yet because I know the tumor is on top of it. Here, I'm finding the plane of eclosion between the dura and the tumor. Again, see the two ridges, which I mentioned before. The outer ridge and the middle ridge, tegment tympani, and the landmark for the superior semicircular canal. Here, I am dissecting with the dissector the membranous, the dura outside, the outer layer of the dura, so that I would come across the tumor. I'm using the navigation to make sure. I'm using the Doppler to make sure that I'm safe. And once that is done, then you can actually widen the incision. Sharp dissection is needed. And we continue with the same principle. Dissecting interdural between two layers of the dura, and then you would come across the tumor without actually getting into the cavernous sinus, which you don't want to because the tumor is not inside the cavernous sinus. It has insinuated itself, but it is not inside the medial layer of the cavernous sinus to call it a true intracavernous lesion. Here we are opening the tumor capsule. And once that is done, we start removing the tumor. And usually, most of these tumors are usually a little bit suckable, not very soft, but still suckable. If not, then I would use the ultrasonic aspirator because I know my anatomy, I know my limits. So we continue the removal of the tumor. And the aim is total radical excision of the tumor, not a biopsy and radiotherapy, not a biopsy and gamma knife. Not the gamma knife straightforward. You should not treat anything with radiation unless you cannot remove it with surgery, unless it comes back after surgery. But to use the gamma knife or radiation just like that, come what may, is, to my mind, criminology at its best. So here we are removing the tumor. And you can see I'm getting some of the CSF because I'm coming to this thin arachnoid layer in the posterior fossa. The tumor has done the drilling of petrous apex that Kawasi taught us about. So in the usual case of the petroclival meningioma, I drilled this area to reach the petroclival meningioma. Here the tumor has done the drilling for me. It has absorbed the tumor. What I do is just to keep the anatomical knowledge to know exactly where I am. And this is actually in most of the cases, because as you said, the commonest type of the trigeminal schwannoma, here is the superior petrosal sinus, as you can see. So we'll continue removal of the tumor. Again, you can see the thin arachnoid membrane of the posterior fossa. You can see the filaments. These are the filaments of the gazelle, and this is where the tumor originated. So we're still in the Michel's cave over the gazelle ganglion, and these are the filaments that give rise to the tumor. Here I'm widening the exposure so that I can see the blind corners, but maintaining my anatomical knowledge exactly where it is. Here is the, we can come across the temporal lobe. Again, taking the tumor completely out. Having finished that, I go and control the bleeding spots. This is V3. Here is the foramen spinosum, foramen valley. So make sure that everything is in order. Here is the greater superficial petrosal nerve. This is the cavity, Meckel's cavity within the Meckel's cave, and this is the trigeminal Basilian ganglion, and you can see that this is the V3, and this is V2, and V1 is going this way. I'm using the Doppler now, and you can see the pulsations. You can hear them. So I'm just telling my residents that, my assistant, that we have identified the carotid artery, putting the fat to obliterate the dead space, and then putting the neural grafts from his thigh, fascia lata, layer after layer, and then putting the urogen, and then putting the dural cells. Closing here the temporalis muscle and fascia, and then putting the flap back. So, the histopathology was conducted, studies were conducted by Dr. Osama Farsakh, our histopathologist. He's American boarded, and as I said before, that he and I have published several paper neurosurgical and histopathology. And he reported this as a section showing tumors composed of compact spindle cells, but he could not, there is no definite Antony A or Antony B areas. Myxoid background is seen, and occasional pleomorphic cells are seen, no significant metatic figures. So these are the slides of this histopathology. And then we are using the immunostaining. S100 was positive. EMA was negative, of course. This is not a glial tumor. Progesterone was negative. Factor 13 was negative. And P53 was negative. And Ki67 MIB was 1%. So we are talking about very benign tumor. So this is a benign tumor that can be totally excised without complications, without any morbidity or mortality. Why should anyone in his own mind should be treated with radiation? I ask, and usually there is no answer. So the final diagnosis was a benign schwannoma. Post-operative course, the patient woke up on the table. She should not leave the operating theater unless she is awake. She is not awake, there is a problem, and we have to solve it there and then. The idea of putting patients on ventilator with the claim that we want to rest the patient is false. It is not scientific. It's only in the minds of those mediocre surgeons teaching their residents false information. Brain CT is done the following day. It must be done the following day. And there is brain CT and brain MRI. So this is the CT showing where we were. This is the air mixed with the fat that we have put. And you can see that we were there. The brain MRI is done on the very morning of the first day. Not after a week, not after a month, not after 3 months, or send the patient home and come back and say, oh, there is recurrence. Well, there is no post-operative MRI. This is teaching residents false information. So this is the fat saturation showing the fat the graph that we have put. But again, look at this here, Meckel's cave and the cavernous sinus. So this is the post-operative. This is the patient without any single complication. Eye movements, facial, and then the discharge summary. In addition to detailed consent form, we insist on detailed medical report, stating everything and anything that has been done to the patient. And discharge summary usually is done on admission and is completed on the night of discharge. So everything about the patient and what we have done is described in full details with images, etc., and recommendations and dosages and so on. This is follow-up 3 months after surgery. again showing total radical excision of the tumor without any complications. And this is follow-up. 1 year later, she went back, of course, to Qatar, but we keep following her every year by coming here to Jordan and doing the investigations. And this is follow-up 4 years later without any recurrence. With this, patient remained well without any deficits. This is the last slide. I want to thank my team because this is a multidisciplinary team. I cannot do this alone. And I want to thank the Farah Institution and Foundation, Dr. Farah, late Dr. Farah Zedkilani, who started this institute. My assistants, Dr. Nisa and Dr. Khatib, my long-serving secretaries, hardworking, the anesthesia team, and all the medical and nursing and radiological colleagues of mine. Thank you very much indeed. With this, I finish.
Thank you very much, Dr. Sabaya. I know you've done many multidisciplinary presentations. This is the first multifamily presentation.
Sure.
So thank you very much. Okay, we have it's open now for questions or comments from the panel. Oh, okay, I'll ask a question to start things off. Do you consider use of neuro monitoring for such lesion, specifically extending to or having bulk part in the posterior fossa?
Yes, we do that routinely. The neurovascular, neurological monitoring system, we have it for so many years, and we use it in every case of a skull-based surgery.
Okay, very good. Okay. Questions? I'm sure there are many. Don't be afraid to step up.
Hello.
Yes, go ahead.
Hello.
Go ahead, doctor.
Hello. Good evening. I am
Good
Dr.
evening.
Musa Baidoun, ophthalmologist. Hi, Dr. Ibrahim. How are you?
Hello, Dr. Baidoun.
How are you? Thank you for this great lecture. And
Thank you.
Many thanks to your great daughter for this illustration and this teaching.
Thank you.
I would like to ask you about endoscopic orbital surgery and
Yes.
how you approach that. And is there any danger or risk to the optic nerve or any intraorbital structure in this kind of surgery? Thank you.
Sure. Dr. Baidoun is one of our eminent ophthalmologists, and his question is very pertaining to the endoscopy, especially for the orbit. This is an evolving subspecialty. They are going through the medial or the lateral canthus. They are going through pterygopalatine fossa. They are going through the maxilla. Really, they are doing astonishing things. But the envelope is really being pushed hard, and there are so many publications that are coming up with the use of endoscopy in orbital surgery. Of course, there is risk of injury for optic or others, but in the hands of the experienced endoscopist, which, by the way, needs a long learning curve, but these people have started about 20, 25 years ago. So they have this experience, and I think new generations are coming up to do and to take this further.
Thank you very much, Doctor. Thank you.
Okay, another question or comment?
Hello.
Go ahead, RD.
Greetings. My name is Rami Darwaza. I'm a neurosurgeon.
Hello, Rami.
Hi, Dr. Sphen.
Hi.
Thank you very much for you and your daughter for this perfect and detailed presentation. I was wondering, did you have any malignancy in your series?
No, I did not. No.
If you did, how the management would differ?
Fortunately, I did not. But if you have a malignant case, then if you have done the total radical excision, you can wait on giving radiation, or you can start immediately. Depends on the extent of the lesion, what are the structures involved, etc. But fortunately, I did not have any malignant trigeminal schwannoma. By the way, Dr. Rami Darwaza is from Palestine. He trained in China, and he came back recently.
Well, Doc, you know a lot of people, Doc. Okay, more questions from the panelists? Oh, I'm sorry. let me see. Go ahead, Ann.
I'm Professor Nadeem from Rawalpindi Medical University.
Okay.
Very good presentation, Dr. Ibrahim. Just I was thinking that have you ever tried using glue to cover the base of the skull to prevent any leak from that?
Yes, sure. In fact, we used it in our case. I showed you at the end that I squirted some of the dural sealant by different trade names, BioGlue and Durasteel, etc. I'm not interested with the trade names, but we do use a dural sealant agent to prevent CSF leak, definitely.
Sure. And one more thing, how do you just remove that area from, how do you identify the motor part of the nerve, which is there also close to that area? You have to see, what we see is that if there's a difference in the size of the nerve, a motor nerve is probably much more small as compared to that nerve. So that may be the only point you have to differentiate from the two nerves, the motor and the sensory.
Yeah, of course. You don't need to, but you know where exactly is the motor route in relation to the sensory route. The major part going into the gazellan ganglia is 95 sensory routes, sensory fibers, and only 5% are motor fibers. And as I said, those are going to the muscles of mastication, masseter temporalis, pterygoids, mylohyoid, etc. We don't need to identify this or that, because whether the tumor is arising from the sensory part of the nerve. So you don't really need to look which of which.
Okay. Thank you.
Hey, Doctor, I have a question from Dr. Rania Sabira, who asked, what are the benefits of other approaches like far lateral approach and the translabyrinthine over retrosigmoid? Is there any surgical preference?
Well, as I said, I always say that only to use one approach is to make you a prisoner of that approach. I love the retrosigmoid approach for these trigeminal schwannoma presenting in the posterior fossa. And I showed you some examples in my illustrative cases. I don't see there is any value or added value of using translabyrinthine or doing any of these approaches in cases of trigeminal schwannoma. I have not used far lateral approach for any trigeminal schwannoma, but I used it for foramen magnum lesions. So it's good to use skull base approaches. It is beneficial to learn them. It's beneficial to use them. But again, not on the expense of the patient and not on the expense of the lengthy period of the surgery itself.
Okay, let's see. Any other questions, comments for Dr. Sabea or his daughter? Amir Ali asks, where can we get such cadaveric courses?
Sure, we have one in Jordan, but recently it has not been working for many reasons. Right. But there are good cadaveric courses in the best one, of course, and the one that Professor Roten established in Gainesville, Florida. And I myself attended as a resident and as a neurosurgeon one of these courses. Again, beautiful courses has been done by Atul Ghul in India. Beautiful cadaveric courses. So India, Gainesville, lots of cadaveric places are there. In Jordan, we have one, but as I said, recently it has been closed for some reasons.
You did work with Dr. Broton, right, in Gainesville?
Yes, I did. Yes.
Yeah, I thought I saw.
He's a great mentor, and I always remember his words to me, which I learned very much. So, and he usually said that if God created him, and once he created him, he said, "Listen, Albert, you have to go to the school and finish that, the primary school and the high school, and then go to the medical school for 7 years, and then go for residency program in general surgery, and then go for a neurosurgical residency program, and become a very prominent neurosurgeon. And then God is saying, I will give you a child with a brain tumor. I want you to operate upon him. But after doing so and saving his life, I want to take your life, Albert Roten." And he would conclude saying, If God presented this to me, I would have agreed.
Okay, very good. Okay, any more closing comments, questions, or just you want to say hi to Dr. Sabaya?
Hello.
Go ahead, Modi.
Thank you, Dr. Sphen, very much for the lecture. What I wanted to ask that you mentioned that you like the radiologists to do the classification on their MRIs.
Yes.
Does this affect your approach if you know the classification prior to your surgery?
No, my message was, Mudhi is a very senior physiotherapist in Jordan. He's very well known in Jordan.
Physiotherapist, yeah.
Yes, and your question is very pertaining, Mudhi. The message I wanted to send is this, and I mentioned this in my last lecture. I trained at St. George's Hospital, at Somali Hospital in London, and the senior radiologist there was the man who invented the CT scan, Jamie Ambrose, with Hounsfield, who was the engineer. So Hounsfield and Jamie Ambrose invented the CT scan. This giant of giants of radiology used to come to theater dressed in the gear, changing his clothes, and then go into the operation gear and then get inside to have a look about the lesion, so that he would have seen the MRI or CT before, and then he would seen how the surgery is going, and then he would write his report. So this is how radiologists should do. They should have the neurosurgical and neurological knowledge to write a report. They should know the approaches that we use. They should know the details of that we use. What I wanted to say also is that the reports written are very poor in this part of the world. Most of the reports, I'm not saying all of them, some of them is brilliant, but most of them are poor because the radiologist is not trained in neurology, neurosurgery, anatomy, and radiology. It's 3-4 lines which are really pathetic, because you cannot say the ventricular system is okay, no shift of midline, no aneurysms or AVMs, and that's the report. The report should be detailed. And if the radiologist has seen the classification of trigeminal, then he would give you better the differential diagnosis. He would say this is not to be considered as trigeminal schwannoma, etc. So radiologist job is not a descriptive one. It is to help us in diagnosis, to help us in reaching to the best approach for the patient. And this, alas, pity and regretfully, it is not carried out in this way in our area.
Thank you very much.
Okay, go ahead, Dr. Garuthan, go ahead. Go ahead, someone had a question or comment. I believe Garuthan, is that Dr. Garuthan? You got your hand raised.
Sir, yes.
Go ahead. Go ahead.
Yes. Sir, have you tried temporalis fascia instead of fasciolata for grafting?
Yes, in this case, I used actually fasciolata graft from the patient, yes. I love the physiological grafts, like the grafts taken from temporalis muscle or fasciolata above the other grafts. But if the patient is a female, usually they don't like taking more incisions and more grafting.
Temporalis fascia instead of temporalis muscle.
Temporalis fascia.
Fascia.
Yeah.
What is your opinion on that? Instead of fasciolata, it is another different incision. We have to make it in the thigh.
I prefer fasciolata because you can have bigger pieces of graft. Temporalis fascia, even with delicacy, you can have a small graft. So if I'm in need for a small graft, I take it from temporalis fascia. I preserve the area around it. Or if I need a large one, I use the fasciolata graft. If I'm lost, then I would use the artificial grafts.
Thank you, sir.
Thank you.
Okay, more comments, questions?
John, I have a question.
Go ahead.
So thank you for the wonderful talk here. My name is Akil Pabani. I'm a neurosurgeon in the US.
Yes.
Welcome.
So for some of these trigeminal schwannomas that are dumbbell shaped, so you have a large extent of tumor in the middle fossa as well as in the posterior fossa.
Yeah.
What's your approach? Do you, if you're considering a two-stage procedure, would you consider doing the middle fossa approach first, followed by retrosigmoid? Or do you go by if there's a more brainstem compression and attack that first?
Yeah,
or would you try
sure.
to just go to middle fossa and see if you can get everything out through one approach first?
Yeah. My approach is this: if the most of the tumor is in the posterior fossa, then I will go retrosigmoid, and then you can actually open the tentorium if need be, use an endoscope to see around blind corners. So I'd like to go as one stage by going retrosigmoid if the tumor is mainly presented in the posterior fossa. If it is mainly presented in the middle fossa, like in this case, I would go as shown in this illustrative case that I've shown you. But I'm not hesitant at all to go for two-stage surgery, but I always go for the posterior fossa because the brainstem is the most important.
And then the second question is, do you routinely use lumbar drains for these cases?
The what, sorry?
Do you use lumbar drain?
No, not as a routine, unless it is necessary, because I always believe that any extra procedure has its own complications. So if there is no need, I don't. So in this case, I did not do. But if he or she develops CSF leak, then I would use the lumbar drain.
Even if you are operating on the dominant temporal lobe, because if there's concern about temporal lobe injury or anything like that?
Yes, even so. Even for the lumbar drain, I also go one step before doing the lumbar drain. I do 1 or 2 lumbar punctures. If that did the trick, fine. If not, then I will put the lumbar drain.
Sure.
But not as upfront.
Thank you very much.
Thank you.
Any more comments, questions? Okay, well, Dr. Sabea, this is how this platform shines, is the interaction. They're not just watching you doing a video, they're interacting with you and getting great feedback. So I'd like to thank you and your daughter, and we look forward to your next presentation. When is the next presentation, Dr. Sabea? Next Monday?
If you like, we can do it next Monday or next Sunday, which is good for you.
Next Sunday? Well, whatever.
Sunday 6 o'clock.
That would be fine. That would be fine.
Sunday 6 o'clock, and I'll present, as I mentioned it during my presentation, I'll present this unusual case of abducent nerve schwannoma.
Okay.
This we'll see a lot of anatomy in the posterior fossa and how we dealt with it, etc. And it's a unique case.
Great. I'll go through the schedule. I can't say for sure, but I'll let you know. We'll talk. And thanks to your daughter. Okay.
Thank you.
You're welcome. Thank you.
Bye-bye.
Bye-bye.
Thank you.
Thank you, Dr. Ibrahim and Dr. Asil, for the excellent lecture.
You're welcome, Dr. Sami. Thank you.
Thank you.
Okay, see you there.
See you.